Well done. Thank you, Peter, for your very nice talk. I just learned a very nice new phrase, the physical activity paradox, and you clearly explained to me what you meant by that. I'll have a look at my phone. Some people ask their questions via my mobile phone. I'll have a look at the comments if there are any questions. Otherwise, I'll have the privilege and the advantage of asking you the first question. A lot of my cycling mates are also bricklayers. Do you think because of the deleterious effects in their occupational physical activity, they have to do more cycling than I do in their leisure time to overcome these adverse effects? Or are these general recommendations, regardless of the occupational activity you do, is that the same for me and the bricklayers in my cycling squad?
Yeah, that's a very good question, and I actually don't have a definite answer to that. I think what we know based on the results that we currently have is that leisure time physical activity is good for you. We all know that occupational physical activity may not be always good for you. So yeah, what your friend should try to do is find the balance between the two, and I can imagine that riding his bike very fast will help him improve his capacity and dealing better with the exposures that he's facing during his work. I can imagine that that's true, but we'll have to find out in the future if more research on this topic pops up, whether that's actually the case.
Thank you. We got a question of Jacob Tarp. Can you also read it, Peter, underneath?
Yeah.
I hope everyone can read it. So looking at the forest plot from the WHO presentation, how do you interpret higher mortality in men with high occupational physical activity, but lower risk of getting the diseases that most people die from?
Yeah, that's an important, also an important question, I think, because I posed those hypotheses for this physiological explanations for why there would be differences between occupational and leisure time physical activity, and they're all pretty much based on cardiovascular mechanisms. So you would expect that the effects that we find for all-cause mortality are mainly due to cardiovascular health outcomes, but that's not the case. That's very well seen of Jacob, and I actually don't have a very good explanation for that. I can only tell him that there's that at the moment the evidence just shows it this way, and we have to see in the future if we can pinpoint what's really going on here.
Thank you. In my chat box, I also received another question. Peter, do you think the workers with the occupational physical activity have the knowledge or literacy that they ought to do leisure time physical activity to keep fit and healthy? So are they also aware?
Yeah. Well, and this is, I think this is also a very important point, and I think here's where the physical activity guidelines may be causing some confusion, because this guy who is doing a lot of physical activity at work, this construction worker, may think, oh, I'm already meeting 150 minutes of physical activity a week, so I don't have to do any leisure time physical activity. I may also not be up for it after a long day of work, but I may also not be, I don't even have to do it because I have been active at work all day. So I think, for us as researchers, there's a very important task here to try to get better messages across to also to these people who are physically active at work. And that's my answer.
Thank you. I'm looking at my mobile phone. I'm looking at, hey, we got a comment. I'll check the comments. Oh yeah. Did you see differences in the paradox for men and women? Thank you, Nige.
Yeah. So what I showed in the slide from the WHO, where we looked at all those different health outcomes, we actually saw that there was actually only for one health outcomes stratified analyses were presented. So that's actually a limitation of the literature as well, that a lot of those reviews, a lot of those studies do not stratify for gender, and I think that should be done because we in our review on all-cause mortality actually did find differential effects for males and females. We saw an increased risk of all-cause mortality for males, but no effect for females. I think that may have to do with the fact that those high demanding jobs, bricklaying, construction, building the roads, those are typically male dominated jobs. Of course, we also have high demanding jobs where we see a lot of females, for example, nurses, but in general, I think physically active jobs are quite male dominated, and my hypothesis would be that we see differential effects between males and females because of that. But it's important that in future research, also for these other health outcomes, we start stratifying for gender.
Thank you very much. Looking at the comments, my phone, I got another question, Peter. Last week, I learned from a colleague about the teachable moments in life, maybe a moment in your life that you start change your behavior, which was previously not possible. Do you think there are some early indicators, for instance, family physicians or occupational physicians or sports physicians can use as a kind of teachable moments that may, people of my age say, well, Paul, this is the time in your life to change your behavior, to live longer, more healthy. Are there any early indicators for certain diseases, or have you any thoughts about that we can use?
Well, I'm not sure if I follow your question completely, but I can say this about it, that I think when it comes to behavior and in particular physical activity, it's important to start educating people as early as possible. We know from studies that behavior that you develop in early childhood that tracks through to your adulthood and later in life. So I would say let's start as soon as possible with giving people the right messages about physical activity. Of course, physical activity at work only starts when people reach adulthood. So probably for work it starts around that age, adulthood.
Okay. Do you think health examinations? Yeah. Do you think health examinations might help? That you get provided data about your risk on cardiac disease, osteoarthritis. They show you.
That may help indeed, because like I just told you, the people who are physically active at work, they may actually think that they're doing the right thing, because they are active all day and they are reaching physical activity guidelines, and maybe by getting them a better understanding about their health, that may maybe help for them to get a better grasp on what they should, how they should behave, like what they should do in terms of their physical activity behavior.
Okay, Peter, thank you very much for your wonderful presentation, your clear thoughts and answers about the questions we have asked. And then I'll propose we switch to the third presenter. Welkom, Alexander Hoorntje. I know Alexander. Since recently he's a resident in orthopedic surgery. He's also a PhD student. And what I learned from surgery, well, surgery may do 30% of recovery, and the other 70% you do in rehab. And Alexander knows about goal attainment scaling and what that might bring after surgery.
Okay, thanks, Paul. And a special thanks to my mom for letting me use her hopefully stable Wi-Fi connection. I'm going to talk to you about a slightly different topic, namely rehabilitation after knee arthroplasty surgery. And we used a concept for this named goal attainment scaling. And I'm going to tell you some more about that. So we as orthopedic surgeons, or in my case, aspiring orthopedic surgeons, are facing a significant clinical challenge because 20% of our total knee replacement patients remain dissatisfied despite their surgery. And in the last few years, it has been well established that meeting preoperative expectations is the most important predictor of patient satisfaction. So what we see nowadays is that our knee osteoarthritis patients are becoming younger and younger, and there are three explanations for this. The first one being the obesity epidemic, causing more and more knee osteoarthritis later in life. The second one, which we also talked about in the first presentation today, is higher levels of participation in sports and concomitant knee injuries, which also cause secondary knee osteoarthritis later in life. And the third one is a more mechanical or design issue, because knee arthroplasty designs are continuously improving and their survival rates are already far better than they were 20, 30 years ago. So we can also safely provide our younger patients with knee arthroplasties because the risk of revision is way lower than it used to be. So with this younger population, we see that we also have patients with higher expectations. They want to go back to skiing and leg with their family. They wish to get back to work after their surgery in, for example, a shoe store. And also it's important for them to be able to walk in the park with their dog and their husband. And our team believes that to meet all these high expectations, it's very important to use goal-oriented rehabilitation. And for my part, I'm also trying to bridge the gap between occupational and sports medicine. So here's another example, which I will use during this presentation. Sorry, there it comes. Slide hiccup. There we go. So what you saw here was one of our key national players, Memphis Depay, who ruptured his anterior cruciate ligament almost 6 months. It was at the end of 2019, before the initial start of the European Championship. So that was a big blow to basically the whole nation, because it was predicted that he would never be able to return to his job, soccer or football, within 6 months of this surgery. I'll get back to that in a bit. But first, I'm going to tell you a bit more about the concept of goal attainment scaling. This was initially developed mainly as a measuring tool by Kirosuk and Sherman in 1968. And they developed this scale to be able to measure improvements of their patients in rehabilitation settings between groups. So every patient has his or her own rehabilitation goals, but based on their goal attainment scale, they were able to compare improvements between their patients on a group level. So it's a busy slide, but the most important thing for you guys to remember is one rule. Everyone who reads this scale should be able to perform the measurement and measure the goal and the outcome with their patient without the help of anyone else. So it should be super clear to everyone. And therefore you need to describe the setting as exact as possible. The method of measurement and the patient instruction. So what are you telling your patient and how should they perform the goal? And then you have a few steps here, and you start with the baseline measurement, which is -2, and that is a description of the baseline outcome. So before the start of the rehabilitation, you measure the patient level or the performance of the patient at that point. And then you discuss with your patient the goal, which is 0, and that is the patient's desired outcome. And based on this goal 0 and baseline -2, you complete the other steps of the scale, with -3 being a decline or an outcome that's worse than the baseline measurement, -1 being an improvement from baseline but still not the goal, and +1 and +2 being improvements that even exceed the patient's desired outcome. So I'll give you a few examples of goal attainment scaling skills in a bit, but first a bit more information on the requirements of a good goal attainment scaling scale. First of all, it's important that the goal should be formulated together with the patient. So the whole team, which may consist of rehabilitation specialists, physical therapists, orthopedic surgeons, and clearly the patient and his or her family, should support and agree the goal. Next, it is established that the goal attainment scaling goal should be described at the activity or participation level of the International Classification of Functioning, Health and Disability. So an example of an activity would be walking the stairs, and an example of a participation goal would be going to the cinema or the grocery store. Next, it's very important, you already saw it in the example I gave earlier, that the goal is formulated in a SMART way, with SMART standing for specific, measurable, achievable or attainable, relevant and realistic, and time-bound or timely. So the example you see here, patient can walk the stairs, is clearly an example that's not SMART. It's not specific, it's not really measurable. It may be achievable and relevant to the patient, but it's also not time-bound in this example. So this is not what you want. So the same goal, but then formulated in a SMART way, could be within 3 months of surgery, a patient can walk up and down the stairs of the rehab center, just 20 steps, and he or she will use the one handrail, which is on the same side as the handrail at his house. So that is a SMART goal. And more or less in line with that, a GAS scale should only include one variable, which could be, for example, distance, time, or number of repetitions, to always allow for an adequate measurement. And it's also part of the SMART phrase. So once more, the goal should be formulated together with the patient and the healthcare providers. It should be SMART at the activity or participation level of the ICF, and it may only include one variable for each goal attainment scaling scale. So I was invited to give this talk because we used goal attainment scaling rehabilitation in a randomized controlled trial, our ACTION trial, where we included 120 patients who were below 65 years of age and were still working at the time of surgery and who wished to return to work afterwards. And they were scheduled to undergo either unicompartmental or total knee arthroplasty. And for our intervention group, our patients were randomized to undergo goal attainment scaling rehabilitation. And here they were invited to visit a physical therapist prior to their surgery to set 3 goals: an activity of daily living goal, a work goal, and a sports or leisure time goal. And these goals were actually measured for the baseline measurement, -2. And then these goals were used to monitor the patient's progress over time until the follow-up 1 year post-operatively. And we also included another group of 60 patients who underwent standard rehabilitation without any of the previously mentioned extras. And our outcomes were visual analog scales from 0 to 100. And we asked patients for their satisfaction with their performance of activity. So their performance of activities of daily living, work activities, and sports or leisure time activities. So now to get it a bit more practical, here you can see an actual work goal of one of our ACTION trial patients. She was a 50-year-old female with left knee osteoarthritis, and she worked as a cleaner and had to clean windows every day. For this, she uses a step stool, which is 40 centimeters in height, and she has to step up and down the step stool to clean 20 to 30 consecutive windows daily, and she wishes to return to her job within 3 to 6 months. So the method of measurements could be as follows. A physical therapist observes and counts the number of times that a patient can step up the stool with her left leg and step down with her right leg while she's carrying a bucket of water. And the patient instruction would be step up the stool with your left leg without support and step down the stool with your right leg, and repeat this as often as you can. So this is the scale that we developed. Prior to her surgery, she measured the number of steps she could do with her painful knee, which was 4 to 6 times. This is an average of 3 measurements. And her goal, as stated, was to be able to step up and down 20 to 30 times. So this is the scale we developed for that, and that we use to monitor progress after the surgery. So again, to bridge the gap here, I also made a work/sport goal for our male professional football player Memphis, who is recovering from his ACL rupture and repair. And it's essential for him to be ready for the European Championship 6 months from now, pre-corona this was. And the method of measurement would be that once the player was cleared by his medical team, he would join his team for an official football match. And the team doctor would use a stopwatch to measure the number of consecutive minutes he was able to play. And the patient instruction in this case would be easy: join your team for an official match and play for as long as you can. And here his goal would be to play for 51 to 90 minutes, more or less. 90 minutes would be optimal. And at baseline, at the start of his rehabilitation, he wouldn't be able to play more than 10 minutes. So as you may notice, the goal itself is clear, but this is not the rehabilitation scheme. So what we asked our physical therapists to do is to develop individualized rehabilitation schemes based on the specific goal attainment scaling goals of each patient. So for each session, they would set up a treatment goal and a treatment method, and they could use the goal attainment scales to score the improvement of the patient. And here you could think of treatment goals such as decreasing the swelling of the knee, improving the range of motion, improving core stability, or any other treatment modalities they could think of. But the most important thing here was to tweak or to specify the rehabilitation to meet the patient's specific goals. So for our European Championship player Memphis, it may look something like this. He would start with isometric quadriceps training, some proprioception training in the gym, some specific field training, some more running and core stability training, even more workouts in the field, more proprioception, and finally, because it's a 26-year-old football player, so some partying as well to keep him motivated for the rest of his rehabilitation. And although many of the 17 million national head coaches that we have in the Netherlands would strongly advise against this, 2 months after his ACL surgery, he was already on the field, and that looked like this. So what's important to remember is that with his goal of playing 90 minutes as an official soccer match, Memphis would tweak his rehabilitation, for example, with these exercises, to actually attain his goal. Now, for the last 3 slides, I would like to take you through some results of our action trial, which I just introduced. Here you can see the goal attainment scaling scores at 3 and 6 months, which were the fixed measure points for our scores in the study. And as you can see, at 3 months already, patients were improving from their initial baseline measurement, which was -2 for ADL goals, work goals, and leisure time goals. But many had shown an improvement, but were not yet at their desired goal, even though some of them had already achieved more than their goal, which is represented by the 1 and 2 in this graph. And then at 6 months, luckily, we saw that almost all our patients had at least achieved their goal, and many more had even achieved more than their goal. And this also suggested to us that their goals, which were 0, may not have been as ambitious as we thought. So they could have gone for a bit more if you see these improvements at 6 months. So here you can see the main outcome scores of our action trial, which were the satisfaction scores with the performance of ADL work and sports activities. And as you can see, for all these activities, the satisfaction significantly improved over time. And we found a significant difference between the intervention group, which used goal attainment scaling rehabilitation, and the control group for the work outcome measure, where the patients in the intervention group were significantly more satisfied with their performance of work activities compared to the control group. And it's also always dangerous to talk about trends, especially when you're in a Friday lecture series with a lot of scientists. But as you can see, an almost similar increase was observed for the sports leisure time satisfaction scores. But we used a cutoff of P is 0.01 to correct for the 3 main outcome measures that we included. And this difference did not meet that P is 0.01. For the ADL scores, we saw a very similar improvement in satisfaction and maybe somewhat of a ceiling effect for both groups. So this is my last slide with some take-home messages. Goal-oriented rehabilitation facilitates goal attainment and thereby may improve satisfaction. I'd like to point out that goal attainment scaling is a tool to facilitate individualized rehabilitation. We're not saying it's the holy grail of rehabilitation, but we believe that it's a nice next step in rehabilitation for knee osteoarthritis patients to try to somewhat individualize or personalize the rehabilitation to meet their own patient-specific goals. And if you're inspired after this talk and you want to start using goal attainment scaling in your daily practice, you may check out the free goal attainment scaling app. It's called Gold, and here you can develop goals for every one of your patients, or even for yourself if you would like to, and you can measure your improvement over time by scoring the goal attainment scores at many different time points. So go check that out. And for the Dutch people in our audience, there's also a freely available goal attainment scaling manual, handleiding, which you can download. It has a great step-by-step instruction of how to use it and how to set up adequate goal attainment scaling skills. So go check that out if you're interested. And that's the end of my presentation. So there's room for some discussion and questions.
Yep, I unmuted. Thank you very much, Sander. Also addressing the issue that all working Memphis Depays, if you're a cleaner, if you're a normal worker, also should receive the same rehabilitation in the Netherlands. Well done. I already received a question. You just became a resident in orthopedic surgery. How do you apply goal attainment scaling in your own clinical practice? Or what are your plans?
Yeah.
Or how would you see it ideally?
So those are 3 questions in one, I guess. So at the moment, I'm trying to discuss with my knee osteoarthritis patients, first of all, their goals. Are they realistic or not? Because that's part of the preoperative expectations that we talked about. And if a patient has very unrealistic expectations from his or her knee arthroplasty, for example, running a marathon after the surgery, and it's important to address that prior to surgery and to tell your patient, well, that's probably not going to happen, but maybe you should try and give golf a chance. And the next question, ideally, I would, for example, use the goal attainment scaling app I just showed you and try to let my patients set up 3 personal goals for their rehabilitation and to follow up follow up their goal attainment scaling scores via an app or via email or via whatever. So we can discuss their progress during our follow-up visits in the hospital, and I can also stay in touch with their physical therapist to discuss any problems during the rehabilitation. So making more of a team effort where the patient is also actively participating in the rehabilitation.
Thank you very much. We got a question from NV. Well, do you expect the same results if you would use the goal? There's no in-between steps. So I think only the zero goal.
That's a good question. I'm not entirely sure. I think it's important for patients, and that's why we also pointed out that it's important to measure the baseline outcome, so prior to surgery, because patients tend to forget their performance from a few months back. So it's important. You can use the goal attainment scale to show them, well, actually, when you came in, you weren't even able to walk for 5 minutes without having to stop because of knee pain. Then at 3 months, you were actually improving because you could walk for 10 minutes, which was -1. And we are still working towards the ultimate goal of walking for 30 minutes without having to stop. So I think that in-between step might motivate the patient to carry on and to see that they actually are improving, despite it might not feel that way.
Thank you. See if we got any other comments or questions. Yes. You already addressed it a little bit, but what are the working ingredients of goal attainment scaling? Is it attention? Is it the team effort? Is it setting realistic expectations? Is it that the physiotherapists might more smartly invent exercises, whatever, to reach your goal? What do you think are the working ingredients of goal attainment scaling?
Oh, that's a great question and a great answer in itself as well. I don't have to say anything more. No, I think it's a bit of all of that. I don't think that, as I said, goal attainment scaling is a method to improve rehabilitation, we believe, but it's based on all those ingredients. So setting realistic expectations, monitoring the patient's progress adequately, participate with the entire team, so the physical therapist, the orthopedic surgeon, the patient and his or her family, and also trying to trigger your physical therapist to go the extra mile in their rehabilitation. So don't do the standard range of motion exercises time and time again, but try to adjust or tweak your rehabilitation to a patient's goal. If it's walking for 45 minutes, you may need to do some more than just improve the range of motion of the knee. You also want to train their stamina, set them on a treadmill. So it's a bit of all of those ingredients, I guess.
Thank you. And including shopping and partying, I learned from Memphis Depay.
That's right. Yeah, you also need to keep that in mind.
Thank you. I received another question. Goal attainment scaling seemed to have an effect for leisure time and work, but not for activities of daily life.
Yeah.
Do you have an explanation for that?
Yeah. As you saw in the graph, there was a sort of I called it a ceiling effect when I showed you the graph, but I guess satisfaction is never going to be 100 points on a scale from 0 to 100. I think all of our patients were pretty satisfied with their activities of daily life, but what we found in our studies with the action trial data is that the ADL goals weren't very ambitious in terms of activity levels or METS scores. So these were relatively easy goals, and both the control and the intervention patients attained those goals, but it wasn't very, how do I explain it? It didn't really feel special while returning
Not
to
challenging.
work. Exactly, yeah, that's what I was looking for, yeah.
Okay, thank you. Yes, a question again by Nikkei. What will be the place for goal attainment scaling in the rehabilitation of patients with low health literacy? A nice bridging question. between talks?
Well, I don't think low health literacy would be a contraindication for using goal attainment scaling in practice. Every patient can express his or her goal, whether you're highly or low literate. It doesn't really matter, in my opinion. So, yeah, I don't see why you couldn't use it for those patients as well.
Okay, thank you. Another question I received is you talked about the goal attainment scaling app. Is that for the practitioner? Is that for the patients? And are there any downsides regarding health literacy or maybe older people not acquainted using apps? Do you have any ideas about that?
That is a good question. Well, it's a fairly simple app, but both the treating physicians or the physical therapist or the patient his or herself could use it. But it's mainly something, and it's still pretty simple at this point. So it could use a few updates, in my opinion. But if you could share it between patient and physical therapist, and the patient himself could measure the goal. For example, at home, and then the physical therapist could see is he or she improving, and if not, what should we do in our next visit to try and improve on that goal.
Okay. I saw in your slides that patients reach their goals even improved even after 6 months. And I think most rehabilitation is within the first 3 months. And they also reached +1 and +2. What does that say that of the clinicians managing the rehabilitations? Do we have too limited expectations of surgery? Do we have too limited expectations of what people can do? Just like you show with the 2 months, or the Memphis video already doing stuff no one would allow. Is it also for the normal patient the case that we are too hesitant, worrying about where the surgery breaks up or whatever?
No, I guess that's a good observation, and it's likely true. We looked at it with orthopedic surgeons and physical therapists and occupational experts. So it was an expert team, but we judged the goals 0 to be quite ambitious enough. And our patients showed us that they improved way more than their goals. So I guess these data show that for our knee arthroplasty patients, which are below 65 years of age, young and active and still working, you can actually have pretty ambitious goals because they tend to reach those goals.
Thank you. Hey, I'm very happy. One of my and Mario's students, Kim, has asked a question. So her team, just like in Harry Potter, receives 5 points for the total competition. And the question of Kim is, the results show that some patients declined from baseline. Were there any observable common characteristics between these patients who declined? Well done, Kim.
Yeah, that's a good question. Maybe even 10 points for the
Okay,
group.
10 points hereby.
So common characteristics, well, you can see it's 5%, so it's a very low number. It's at 3 patients. But as with normal knee arthroplasty surgery, you always observe some complications. So stiff knees that don't bend far enough, reoperation due to infections. It happens maybe once in every 100 cases, but we had a few in our study. But we didn't specifically look into the patient details of these -3 scores, so the declining scores. That would be a nice suggestion to do in the future. So a great question by Kim.
Okay. Last question. What is your take on the everyday rehabilitation? Is it mainly move more and sit less, or can it be too much or wrong physical activities? So what is your take on the everyday rehabilitation? Is it mainly move more and sit less, or can it be too much or wrong physical activities?
For knee arthroplasty patients specifically, or
pick?
I guess
Pick for knee arthroplasty.
So I guess with our knee arthroplasty patients, what we see is that it's more often physical therapists and patients are too cautious, and thereby slowing their rehabilitation, than that they're overdoing it and causing harm by that. So for knee arthroplasty patients, I would say do as much as you can because you will because it's likely safe and you will improve more by it.
Okay, thank you very much. Very clear advice. Again, thank you very much, Alexander, for your very nice talk and answering all those questions.